I'm Anthony So, and I'm here at the Sanford School of Public Policy, the Program of Global Health and Technology Access, and it is my honor to introduce today's speaker kicking off Global Health Week at Duke. 15 years ago, in 1996, a milestone in AIDS treatment, and the treatment of AIDS happened. Triple drug therapy, the use of the combinations of 3 drugs together, transformed the death sentence that was AIDS into a chronic disease. But when I joined the Rockefeller Foundation in the late 1990s, 25 million people with AIDS in Africa had no prospect of treatment. The AIDS cocktail cost $10,000 to $15,000 per patient per year, and some experts in public health argued that implementing AIDS treatment in Africa was not possible, that it was too expensive. The problems of drug resistance would be insurmountable. But one of the leading voices in Africa on AIDS was Peter Mugyenyi, director and founder of the Joint Clinical Research Center in Kampala, Uganda, that since its founding in 1991 has grown to over 300 scientists, doctors, and medical staff that have initiated treatment in over 70,000 patients on AIDS combination treatment, more than half of the total of the 140,000 people being treated for AIDS in all of Uganda. A pediatrician by training, the author of Genocide by Denial, he once said, "My mission is to my patients is to provide them with the best therapy available, and if it's not available, to go out of my way to get it for them." He reminded us that 25 million lives are a lot of lives to lose, and that one could not imagine that AIDS prevention would succeed if voluntary counseling and testing only promised a lifetime of stigma and no prospect for treatment. That AIDS cocktail, by the way, which started out $10,000 to $15,000, became $360 per patient per year, and now goes for less than $100. And the price of hope now seems possible, but only because of dedicated work of physicians like Dr. Mugyenyi to bring treatment to their patients living with AIDS. And in January of 2003, Dr. Mugyenyi was a special guest of First Lady Laura Bush, during President Bush's State of the Union address to this country, when the administration unveiled PEPFAR, a commitment up to $15 billion over 5 years to turn the tide against AIDS. Today, though, his journey continues, as of course the economic crisis and other reasons seem to have flatlined the support we have for our commitments to continue the treatment of those with AIDS in developing countries. And on the final stop of his 4-campus tour that began at the University of Michigan and continued to Yale, then Harvard, and now at Duke, here to discuss the unresolved AIDS crisis in Africa, why U.S. investment matters, please join me in welcoming Dr. Peter Mugyenyi.
Thank you. Thank you, Anthony. And thanks, faculty, students, ladies and gentlemen, for coming to this talk. Perhaps I should mention that part of the reason I came to the US was to attend a memorial symposium for a student at Michigan University, Sujar. He was working with us in Uganda and unfortunately died in a road traffic accident. He was an exceptional student who had worked on global health. He was truly a man who worked in wherever you put him, he would fit there. And in Uganda, he had already started working in a global village and making a lot of difference and influencing a lot of lives. So it was befitting that I come to be at his memorial symposium. Today, I want to talk to you about AIDS and the journey that I've traveled and where we are today and where I think we might be going. And because many of you were young in 1990 and really did not experience the desperation of the time, I'll take you a little bit back to the beginning so that you could see what was happening at the time. I bring you greetings from the center of Africa, and as I said, I want to take you to the time when AIDS killed everybody it affected. Those were the bleak days of PEPFAR. The situation was so terrible, it was so desperate, that even soil was fought over. Anything that was said to treat AIDS, thousands of people would rush there, and not only from Uganda, but from all the neighboring countries to try and escape death. And that's how desperate the situation was. It cannot be expressed better. On this graph, I don't know whether we have a pointer. It clearly shows that the mortality was very, very high. The declining graph the means by 5 years, people diagnosed with AIDS, over 90% of them would be dead. So it was truly a death sentence. What happened across the continent? Life expectancy had been rising from 1950s in Africa as health conditions improved, as immunization was realized, and disease control was beginning to take effect. But then from mid-1980s and to 2000, we got a fall in life expectancy. Now, in a country like Zambia, life expectancy fell to as low as 33. And as we speak now, life expectancy in a country called Swaziland, it is 28 years only. This is what happened. This is what Anthony referred to from 1995, when highly active antiretroviral therapy were introduced in Europe and United States. The death rates just stopped. If you can see, they were rising just like it was the case in Africa, but the death rate just stopped as soon as antiretroviral therapy was introduced in 1996. The AIDS situation in Africa was so bad that it brought all the healthcare systems to a standstill. The hospitals were so overcrowded with patients, you couldn't, as a doctor, you couldn't even get space to do a ward round. You'd go stepping on people on the ground, very sick, under the bed. The hospitals just could not function. This was a hospital in Kinshasa, but hospitals in Uganda and other places were no different. And all of these were people dying of AIDS, and doctors had nothing they could do for them. Meanwhile, the situation, AIDS hit Africa at the time of very dire economic and economic situation. There were laboratories in the field. Laboratories, and more means laboratories without walls, which were in the field. That's how desperate the situation was. So the continent was ill-prepared to deal with this huge problem of so many millions of people being dying, and the continent couldn't cope. As Anthony said, what that situation called for was it was a state of emergency in Africa. It called for mobilization of world's resources to rush to Africa and try to tackle this problem. But what was said at the time was that public AIDS treatment in Africa was impossible. Infrastructure constraints were insurmountable. And what was recommended were only preventive initiatives. There were discouraging statements that were made at the time, that the drugs were too sophisticated to be used in Africa. That was a statement made at the conference that announced success over AIDS. And someone was even a little bit more crude and said if AIDS treatment was just a glass of clean water, Africa would not afford it. And someone said these drugs require precision timing in order to work, and yet Africans cannot tell time, and they rely on the sun. He added he shudders to think what would happen if it rained and somebody was on antiretroviral therapy. But evidence started accumulating to disprove those. Brazil started to use antiretroviral therapy, and very successfully too in the public sector. My center, the Joint Clinical Research Center, started a program that proved feasibility. Paul Farmer in Haiti, which is one of the world's even much poorer than most of the African countries, he was treating AIDS in a place called Kanj. And MSF, which is a charity organization, also started providing antiretrovirals. But all of these were providing treatment to a very tiny minority of people. And in Uganda, it were those who could pay, and they were so few. But we proved the concept. Treatment was feasible in Africa. So Paul Farmer, he said this statement as we were trying to, as we discussed with some policymakers in the phases just before PEPFAR, that life-saving antiretroviral therapy was possible in any community. That is me emerging from one of the hearts of nomads to see not a patient, but to see head of the household in a place where we are introducing antiretroviral therapy. I dug up this slide. I used to go around US and talk to people like you. Those days it was very important to let everybody and keep repeating that antiretroviral therapy was feasible in Africa at the time when everybody was saying it was not feasible. But where was the proof? And what was the extent of this? Now, Rockefeller Foundation in 2000 commissioned me and my colleagues to go and study the AIDS situation in Africa and report back the extent, the magnitude of the problem, and make recommendations on what could be done about this problem. I was assigned to study AIDS in East and Central Africa, and my other colleagues studied other parts of the continent. What we found, although we already knew that the situation was bad, truly shocked us. We found an ignored human disaster causing untold suffering. Mayhem and death was raging in most parts of sub-Saharan Africa. What followed after this was a Kampala meeting where we presented our data. It was about 60 pages per of data which we presented at AIDS in Africa meeting in Kampala. Important people attended this meeting, and including policymakers, AIDS activists, UNAIDS, World Health Organization, and our data was truly shocking and to this audience. Some of them, it was their first time to realize the magnitude of the problem of AIDS in Africa. All that we found by way of intervention, by way of funding, were poorly funded preventive initiatives that were generally ineffective because, and they were also failing because the epidemic was continuing to spread. So the sheer magnitude of the AIDS disaster in Africa constituted a state of emergency. And there was an urgent need and a moral imperative to do something about it. And we called at that time not only to rich countries to do something about it, but everybody in the world, all countries in the world, to address this emergency that had hit the continent. And the key recommendation was that prevention alone, which was prevalent at the time and was ineffective, would not work. And we needed to have both treatment and prevention together. At the same time, there was rising protests by civil society because coming out of our research and the data that we presented and the situation that was unfolding across Africa, the protests were mounting, and initially they were against the pharmaceutical companies, and later on the countries themselves and the governments were involved. The protests which were focused on pharmaceutical companies was because of the costs. You had a bit of it. The drugs were very, very expensive and unaffordable to any of the developing countries, except perhaps Brazil, which had to break patent law in order to start providing treatment to their communities. The protests resulted in AIDS being put on the G8 agenda. If you recall, G8, these are the most industrialized countries in the world. Wherever they met, they would meet with a barrage of protests, and protests were about a human rights issue and a human catastrophe that was taking place where they were not doing much about it. But then in 2006, 2005 actually, they started planning something. And at the same time, earlier on in 2003, that's when Global Fund and PEPFAR got established. Now, I want to tell you about PEPFAR. For a program of treatment that was said to be impossible, PEPFAR has truly done wonders. This little kid is called Paul. And in June 2005, people who saw him thought that a miracle had been performed, because when he came to our clinic, he was in coma. And when he woke up in June 2005, he did so because of PEPFAR program. He's just an example. Kids like him used not even to be brought to hospital because there was no treatment. And the little treatment was usually reserved for adults because it was thought kids would not recover. But by a year later, Paul was back at school. He became a talented musician and kept turning up at our Christmas parties to give us most momentous performances. And at some time, he was like a DJ and doing some jingle. The response to PEPFAR was overwhelming. So many people turned up. This is one of the clinics in Western Uganda. I went over there to inspect what was happening. On one day, these were patients who had turned up, and the picture doesn't have. This is a queue to see one of our doctors. The queue continues here, and this is the waiting room where they were being registered. You see they go out of the building into the compound, and all of these people were destined to die if PEPFAR had not been there. And virtually all of them are doing their own work, and they are well because of PEPFAR. These people, incidentally, because of the human resource constraint, were being cared for by one doctor, one clinical officer, 2 nurses. And to cover all of these we sort of trained other lower cadre people to do the repetitive work so that we could make sure that everybody gets access to treatment. And since then, we've been transforming things. You saw we would get labs like this and convert it into laboratories like this one. And I went to one of the places to work, and the building they gave me was in that shape, but I turned it into this one, and we were able to continue. And all of this was happening in a relatively short time. This is now our headquarters, where the Joint Clinical Research Center is, and where my office is. But this one was not funded by PEPFAR, but because PEPFAR was taking care of so many other patients, we were able to save some of the other resources to build infrastructure. And this indeed could be attributed to PEPFAR, one of PEPFAR's success, because without it, we wouldn't have come to a stage where we are beginning to build some decent facilities where we can begin to provide quality services to the patients. Because Joint Clinical Research Center started early, we shared our experiences with the rest of the continent. We were funded again by Rockefeller Foundation. Anthony might know about this, African Dialogue on AIDS, ADAC, and AIDS Care Research in Africa. With these two programs, the research in Africa would get young scientists like yourselves and provide them with a research grant. And this research grant enabled them to undertake their first projects on research on AIDS and TB. And they would learn how to carry out research. And then the aim was to make them independent scientists, researchers, who would be able to compete for research grants and eventually be able to take over from people like myself and do research and treatment in their own countries. African Dialogue on AIDS was very, very successful. The reason why it was so successful, we wouldn't go, say, to a country like Nigeria and say, guys, we have come to teach you how to treat AIDS. Nothing of the sort. We'd reach there and say, guys, we need to share experiences. We have come to learn from you what you are doing, and you learn from us. And together, we see which best practices we'll be able to carry forward. And we were able to, these were some of the countries that we coordinated from our center. And in each of these countries, there was a researcher, and each researcher was supposed to spread best practices that we had developed in his own country and become a leader and mobilize others to move forward. I'm very glad to say that most of the researchers now compete for their own grants, and successfully so as well. Now, this is what is happening. The lower graph, we had seen it before, where we are losing 90% of over 90% of people diagnosed with AIDS. Now, over 90% of people diagnosed with AIDS are saved. They don't die, they survive. Now, this study is a DART study. It is published. It involved people who were very, very sick. But now with the PEPFAR, we are beginning to get people who are not so sick after the first year and the second year, and survival is even better than this. So hardly anybody dies. Nobody dies these days, or very few people die when we start the mono AIDS treatment early, and they live highly productive lives. And this is what is happening as a result of PEPFAR. So the success of PEPFAR makes it America's biggest humanitarian mission to Africa and perhaps to any other country. There are some biggest mission may be military, but for a humanitarian cause, this has been the biggest. It is not so big in money, it is so big in the success that it achieved. There is nothing in the African continent that the United States has ever done that surpasses this mission to Africa. You have currently over 6 million lives saved. About 6 million people are getting antiretroviral therapy as a result of PEPFAR and Global Fund. Global Fund, the biggest contributor is United States. So you can never know. I went with the U.S. ambassador to that place where I was in the hut. Actually, the U.S. ambassador also went inside with me in that hut. And although he was the ambassador, he came out in the same style as I did to crawl out. But the ambassador was swarmed by grateful people saying, "Thank you, America. Thank you for saving our people." Jimmy Coker, the ambassador, I remember telling me that he didn't know that America was so appreciated in such a remote place. But that's humanity in action, the sort of action the world would want to see more of. Now, PEPFAR did not just treat AIDS or malaria or TB. It treated many other conditions. It helped to build infrastructure and strengthen them. The healthcare providers, you see, if you are a nurse or a doctor working in that hospital I showed you, you really wouldn't want to, you wouldn't wake up in the morning looking forward to going to work. But the moment the infrastructure was improved, like I showed you our center, you wake up in the morning, you want to go and work. So it motivated healthcare providers because conditions for staff and improved, and then staff were able to go back to their work and work on the other diseases as well. This is what happened across sub-Saharan Africa. The numbers of people being treated all soared, they went up. And as I said, currently, close to 6 million people are being treated on both PEPFAR and Global Fund. For those who may not know what PEPFAR stands for, it is the President's Emergency Program for AIDS Relief. That's what it stands for. And you can see the numbers have been going up and up. Now, at this particular time, there is so much I can talk about, but perhaps I could just talk briefly on how the AIDS epidemic is like. Currently, close to about 30 million people in the world live with AIDS. Although we have had a successful AIDS treatment program, we are not even treating half of those who need the treatment. We are about 45%. Now, at the same time, we still get lots of people still being infected with HIV. Now, you have people getting infected. For every 2 we start treatment on, about 4, 5 are newly infected. It's just like a tap running and you are trying to mop the floor. You will never dry the floor. So if you are having more people being infected and you are treating less, simple mathematics tells you you are losing the battle. But recent scientific advances have been showing us a way in which we could win this battle. If you look at this data published in New England Journal is from Vancouver in Canada. It shows relationship between plasma viral load and risk of heterosexual transmission of HIV. Now, you see as the viral load goes up, meaning somebody is not on treatment and the disease is progressive, there is a high risk of infection. And as the viral load comes down, there is the transmission goes down. And look, below 400 copies, which is the usual condition we get patients into when we successfully treat them, there is hardly any transmission of HIV. Now, if this kind of data could be duplicated, if we could get this one in a community, then would truly be on the way to controlling HIV epidemic by treating a critical number of people with antiretroviral therapy. So it has been an exciting time until 2009 when there was a global financial crunch. And with the global financial crunch, in Uganda there was a freeze on treating new patients. PEPFAR said, look, there is we have a financial crunch, and no new patients should be started on treatment. Now, there was a dilemma. You know, when you test patients for HIV/AIDS, you find three categories of people. There are those who are negative, so no problem with that. Among those who are positive, there are those who need treatment immediately. And those who need treatment immediately, PEPFAR provided treatment for them. Those who were found to be HIV infected, but not yet at a stage to require treatment, were put in a program of care. And this program of care meant such people would keep coming for checkup every 6 months or so, would do their CD4s. This is a test that determines whether somebody is ready to start treatment. And if we found they needed treatment, we would start it. So PEPFAR promised them that they would be started on treatment the moment they reach the stage. Unfortunately, when the freeze came, these patients were ignored. These people living with HIV were ignored. And it caused us a problem. They would reach a stage and come to us and say, Dr. Mugyenyi, you promised us treatment. Now time has come and there is no treatment. What did you do with my drugs? So it was a very difficult situation for us. Another worrying trend that we saw, there was some sort of a hurry to transition the programs to Ministry of Health. And Ministry of Health was not prepared, at least not in every places. So if you, a program that was so successful, if you transitioned it too quickly to a Minister of Health that was not ready, then you'd break it. It wouldn't succeed. And most painful, we had to turn away patients in dire situations. Here I'm talking about pregnant women who were HIV infected. And so they had a double jeopardy of needing treatment for their own survival and also of their unborn kid. And having to turn them away was a very painful exercise. So this was a crisis. The newspapers in Uganda started worrying as patients and process increased. And I was back in Washington to talk to Congress and other funders to highlight the crisis that had hit our country and spreading to other parts of the continent. We carried out a study to see what was happening, and this study was carried out by Ervin David Bangsberg. I was one of the investigators in one of the centers that was treating AIDS. PEPFAR patients accessing treatment are in red. I don't know why this keeps are in red, and you could see that the majority of the patients were being started by PEPFAR. If you look at April 09, and when the freeze came, the PEPFAR stopped starting new patients on treatment. And after that, other charity organizations started taking some of the patients, but the numbers were not many. those that they could take on. The purple is a charity organization linked to David Bangsberg of Massachusetts General Hospital. Presently, the situation now in Uganda was following the advocacy by people like you and ourselves and others. The freeze on treatment was lifted, and now patients in Uganda are able to access treatment. We don't have to turn away any pregnant woman or anybody who needs treatment. But our worry is that we have a ceiling on the numbers, and the clock is ticking. It is ticking, and we'll soon reach the numbers, and then we'll have the cycle start again. So there is need to plan for sustainability. There is a need to plan for what we do with these people in the future. Now, there are other issues. While we are looking for more funding, because the epidemic is still growing, we recognize that we can improve. Countries which get donations and donors, everybody can improve because we need to respect donor money. Donor money is people's taxes, and people who pay tax go through a lot of struggle to earn that money. So we need to respect it, and we need to maximize this money. And, but we need to establish some better way of making donations work better. We could, for instance, decrease bureaucratic impediments. And these impediments are so many on the donor side. We could do that by involving recipient countries in planning. If we plan jointly, you don't have to plan a very expensive program. What I did in my program was to use whatever infrastructure we had. Some programs, first of all, had to build brick buildings before starting on treating people. So if you plan, you save a lot of money. And then if you plan according to national strategic plans, you don't need to duplicate services, to have parallel programs. And then if you incorporate stepwise capacity building and transition is well planned, and there is also technology transfer, it means that the program, whatever you are doing, you are building capacity within the recipient country to be able to take over the program when you eventually leave. So you have an exit strategy, a donor exit strategy. But also in recipient countries, there is a need to reduce wastage. And we have found in a study that we carried out at the Joint Clinical Research Center that we could actually save up to 1/3 of the money, meaning for the same amount of money, we can treat 1/3 more people without having to increase the funding. So we can do that by good transparency and accountability. There are cost-cutting practices. These cost-cutting practices include avoiding unnecessary laboratory tests where they are not needed. And the study showed clearly that a lot of the monitoring laboratory tests we can do without, especially in areas where they don't have the facilities. And then we can task shift. Instead of having MDs, for example, giving people pills, we can get nurses giving them pills. And if nurses, and we don't need highly qualified nurses, we could get nursing assistants to give the pills to patients. And that way we save a lot of money. Again, we have multitasking. If you are working in an AIDS clinic like I do, people who come with malaria, I treat them. People who come with pneumonia, I treat them. We use the same kind of facilities. I treat many other cases other than just concentrating on treating only AIDS. And that way you save resources. and you cover such a big area and use the same kind of facilities to do much more than you would achieve. And then you can start integrating services. And integrating services is a stepwise process. And when you do that, you begin to save resources so that you can treat more people and also use donor funds more responsibly and achieve many more results than you would otherwise do. Donors also need to plan for long-term strategy. Because AIDS, if you undertake funding AIDS, you need to know it's a lifetime disease. It's not like tuberculosis. Tuberculosis, you treat somebody for 6 months, and then he's cured, and then that's it. But AIDS, you have undertaken a work where someone has got a lifetime disease. So you need long-term strategy. And you don't go and after 5 years say, look, we are running out of money and we are getting out. Actually, there is one program which did exactly that. It was taking care of children. After some years, it came around and said to us that we are getting out. I told one of them, I said, you need to tell this to one of the kids you are looking after. That son, I've been looking after you for the last 4 years, but now you're on your own. But so we need some ethics in that. Now, we need to help poor countries to get out of the poverty trap. Part of these diseases and why they need why countries need donations is because they are caught in a poverty trap. The answer is to, while you are addressing an emergency, and this was truly an emergency, a bigger emergency than earthquakes, tsunamis, in terms of the lives that were being lost. It was a much bigger one. But to solve it, we shouldn't be putting out fires all the time. We need to have strategies that solves it permanently. And this is to help poor countries to go towards self-sustainability. We have part of the tragedy came because the drugs were too expensive. If the drugs had been affordable, many countries could have made an attempt to buy these drugs for their citizens. But the costs, believe me, were just unaffordable. And this is because pharmaceutical companies are protected by TRIPS and patents laws, which restrict the drugs supply. Now, when you talk about these laws, it's not that anybody is against companies making profits. Absolutely not. It's not that anybody is against innovation being rewarded, discoveries being rewarded. This is what drives discovery. And nobody wants to kill the duck that lays the golden eggs. What we say, however, is that how much profit is enough profit? We need to have some sort of control. We need to have some mechanism whereby pharmaceutical companies don't have to make money at the expense of millions of poor people dying. I don't think they feel comfortable. What they need to do is to mobilize poor people to be partners in their business so that they can succeed in their business but carry the people with them. And this links up to solving the poverty trap, because if the poverty trap is solved, the poor people would be some of those who pay for drugs that the pharmaceutical companies make. I want to explain to you how dire this situation is in poor countries. If any one of you falls sick now and you go to hospital, you want to get money out of your pocket and pay the doctor there. You will have maybe college insurance or some sort of insurance. There is nothing of the sort in most parts of Africa. Now, if a villager gets malaria or he gets any infection, however poor he is, he must get money out of his pocket and pay. So all over the world, it is the poor people who actually pay for medical services. So some of the people here, if you go, those that have insurance, I realize there are people here without insurance in the United States, but most of the people don't even know how much drugs cost. Because once he gets the prescription, he goes and gets the drugs. But poor people have to buy all the drugs. They have to watch what drugs they buy. So if the drugs are patented, there is no way they can access the drugs. And all that they can afford are the generic copies. And the generic copies are restricted because of the TRIPS and patents law. There are international trade agreements. These work against the poor countries. They keep them, the markets where they can sell their produce are protected. And therefore, they find it difficult to wriggle out of this trap that predisposes to this condition where they have to need this donation. And there is a question of justice and human rights. All these are issues that governments, not only the United States, but all governments in the world, including poor ones, need to address for a world that needs to function with these international laws that encourage business, but at the same time protect lives. Now, for recipient countries, there is a question of the quality of drugs and affordability. I have alluded to those by explaining to you that we are mainly the people who get money out of our pockets and pay for them. And we rely mainly on generic drugs because that's all that we can afford. Now, when the generic drugs, some people mistake them. They mistake generic manufacturers for charity organizations. They are absolutely no different from branded manufacturers. They are also there in the business to make profit. So they too need pressure. And when you put pressure on them, you bring competition. You let, if there is freedom of manufacturing some of the drugs that have gone out of the patents, the cost always goes down. And we used to tell them that if you don't supply from, we are going to get another generic manufacturers to supply us, and the cost would keep coming down. But some of the donors inadvertently keep the cost up. They don't intend it, but it's a net effect of that. I'll give you an example. There was one of the organizations wanted to help Africa access truly low prices from generic manufacturers. So they went to some of these generic manufacturing companies and said, guys, we are offering you money, but you need to produce bulk products, bulk drugs in bulk, so that your average cost goes down, and so that the people in Africa can access lower cost drugs. And that happened in the short term. Because they are purchased in bulk, the cost went down, but the mistake they made was that they paid for a long period, about 5 years. So from there onwards, that company did not have any more incentive to lower the cost. And secondly, the competitors could only work when they could sell below that cost. And it happened. The competitors soon started producing drugs at a lower cost than that one which had been negotiated. But this one had fixed the price for 5 years and could not supply us drugs which were any cheaper. He killed the competition. Although the intention were good, he killed the competition, and he continued to supply us drugs at a higher cost than the market. But there was worse. Some of those drugs became obsolete. There is a drug called Stavudine. It was discovered to cause unsightly side effects, and so it was discontinued. But he had paid for it for 5 years. And delivery schedules had been fixed for 5 years. So planes kept landing at our airports, delivering this toxic drug. And it would make its way to all parts of the country. And people continued taking this toxic drug. yet it had been condemned. And they couldn't switch to safer ones because they had already paid for this. So these are some of the program issues where both recipient and donors can work together to bring costs down. The moment you bring costs down, the more patients you can treat. Then there is on clinical practice. Clinical practice, if we can minimize resistance. Resistance is one of the biggest threats to successful AIDS treatment, because if resistance occurs in substantial numbers in Africa, we are in very serious trouble. I want to explain to you what trouble we are in. In this country, if one is diagnosed with HIV, and then they determine that somebody needs treatment, before he starts treatment, they do a resistance test to determine which drugs work for him. In Africa, we don't do that. The resistance test costs, using generics, about 3 years of treatment. Just to do the resistance test is 3 years of treatment. Now imagine if you had to do resistance tests to millions of people in Africa, the program would just be a non-starter. So to protect these drugs which are cheaper, we need to make sure that we have got good clinical practice. And good clinical practice in treating AIDS is easy. It's one of the easiest diseases to treat, because all you need to ensure is adherence. But adherence is not possible unless you can guarantee reliable drug supplies. If you don't have reliable drug supplies, then you cannot have adherence, and you cannot have good clinical practice, and therefore you'll get resistance. And if you get resistance, you are creating situations where AIDS will become virtually impossible to treat. And of course, we need to continue having human resources trained and improved upon. There is the issue of ethical funding. Not all funding is ethical. You get people who make mistakes in funding, sometimes unintentional. I've already explained to you those treating kids, for example, and then suddenly you come and say, I've run out of money. I've heard of a story of people who abandoned orphans or started on a research project and just abandoned it. And of course, once you start donation, you need to have a good plan where you are also planning for sustainability. In recipient countries, we need good governance. Good governance, democratic policies, developmental policies, and human rights create conditions that ensure that programs of health can work in peace and development. So there are issues other than just increasing money which need to be addressed as well. These are world leaders. In 2006, they met and decided that universal access was the way to go, where everybody gets treatment. This universal access was well advised, and it was a strategy that was truly going to move us forward towards solving the AIDS crisis in the world. Most of these guys are out of power, not because they didn't fulfill their promises. The majority of those who linger in power are most likely the Africans, because they tend to love power a little bit more than others. But universal access was recognized as a key to winning the war against HIV/AIDS. Part of the reason why it was really so critical, if you have inequitable access to treatment, it is not only unjust because some people getting treatment and others not getting treatment. It compromises the quality of antiretroviral therapy and other health programs, and it threatens peace. When I gave testimony to US Senate, I told the Senate that AIDS was a threat to peace. It was a security issue. You are seeing what is happening in North Africa. We are having a revolution, and this revolution is sweeping away governments. These governments, the people there are dissatisfied with social services. They are dissatisfied with the conditions. Their governments are not delivering. And AIDS, at the extent to which it had reached in 2000, early 2000, it was such a worrying state. People were very, very concerned, and it could have got social unrest, and this social unrest could have caused turmoil. And as I have already explained, inequitable treatment brings resistance, and that would be very, very dangerous. Those leaders, world leaders, promised universal access by year 2010, and they didn't deliver. By year 2010, the situation, AIDS was very, very bad. But they had gone beyond that and promised Millennium Development Goals to be achieved by 2015. We haven't reached there, but I can assure you we are not going to achieve those Millennium Development Goals. Were they wrong? The answer is no. They were wrong because their commitment was deficient. It is their commitment which failed, but the objectives were right. It makes sense that if people are getting treatment, you would avoid all of those dangers and pitfalls that I explained, and then you can concentrate on Millennium Development Goals to be achieved 5 years later, so that you can begin to see the end of donation. It wouldn't be the end of donation, but you can begin to see the end of donation. But currently, nobody talks about these programs anymore. I've not heard anybody talk about universal access. They have abandoned a winning strategy. I've not heard anybody talk about Millennium Development Goals. There is silence about all of those. There is also silence about progress that was being made towards better TRIPS agreement and patents laws. Currently, India is in negotiation with the European community. It has been the biggest supplier of generic drugs to poor countries. When this agreement comes in strength, we are worried that access to generic drugs will be very, very much affected. Currently, because of going back on progress that was being made on TRIPS and patent agreements, even medical equipments are being patented. And worse still, there is even talk of patenting surgical procedures. One of the procedures, for example, I was talking to some of you this morning. If you go, for example, for appendectomy, if somebody has got a better procedure of carrying out appendectomy, he can patent it. And if you are on the table operating and you want to do it the better way, if the patent holder gets to know about it, you are in trouble. I think they are taking this to extremes, you know? And this is where we are going at this particular time. So really, as I come to the end of my talk, we need to recognize that freezing AIDS funding now means that the epidemic will resurge and become more catastrophic and more difficult to bring under control. So really, our joint duty and the voice of young people matters. It's what matters most, because you are the future, is to remind all world leaders, and not only your political leaders in Congress or Senate, but also the other players in Europe and in Africa, that we need to fulfill the promises that we made. The promises that we made to Global Fund was made by all countries. The biggest contributor of money is United States. But the contribution were calculated per gross domestic product of nations. If you use that formula, the country that consistently contributes to Global AIDS Fund is a country called Niger. Niger is one of the poorest countries in the world. So if European countries, especially a country like Germany, which is much richer than most other countries, could give what they promised, not what we would like them to give, but what they themselves promised, then would, as a world, be able to fight this epidemic and win. But here, in the United States, being the leader, the biggest contributor, we need to ask that it takes leadership in increasing contributions so that we can win. This is the current slogan, that we can't treat our way through the epidemic. But the answer is really that we have no alternative. We have to treat our way through the epidemic. If we don't, we have to think of the alternative. The alternative is carnage of millions that are already infected. They are not going to go away. No treatment, they will die. And millions that will be infected because prevention cannot succeed without treatment. This is what you achieve when you treat patients. This is Paul Farmer in Haiti. These people need not die, even if they are in this state. After a few months of treatment, you get that guy who was truly knocking on death's door transformed to a happy, productive member of society. And these are AIDS orphans who used to get absolutely no treatment because treatment used not to be there for children. We have got over 2,000 children getting treatment, and all of them are healthy. We don't have any kid who is sick, and yet all of them came very, very sick, like Paul. And this is what PEPFAR is transforming them into. And we can succeed in transforming all the AIDS, all the people who have AIDS into happy, productive members of society who can make a contribution in economic development and make the world a happier place. Thank you very much. I'll answer some questions and yes.
Thank you very much, Mugyenyi. Michael, I'm a university, a student at UNC. I have two questions. I'm wondering, much as donor funds can once promise there is a moral imperative for them to continue, but once they run out of money, it's really out and they have no option but to pull out. So I wonder what continuing programs are in place, for example, by the government of Uganda in case such funds are to run out. What happens next? If donors cannot continue successful programs, what plans does the government have for other people? And then secondly, I'm curious as to what you think the role of the structural adjustment policies of the 80s had on the AIDS scourge in terms of
the 80s.
Rehabilitating the healthcare infrastructure.
Those are very powerful questions, particularly that one of the 80s structural adjustment. But maybe we start with the first good question. If the money runs out, money doesn't really run out. It is mainly political will that changes. When you really go to the root of it, it is political will that changes. And part of our job is to make sure that politicians remain with political will to do what is right. But then having said that, there is still a situation. They can stop the funding as happened. So what do we do? Yes, we want to be very, very clearly understood. I come from a developing country, but we are most uncomfortable having to depend on donations. we are most uncomfortable. And we are working hard to make sure that we go towards a stage when we would no longer be able to depend on donations. But AIDS, the way it came as a devastating emergency. Yesterday, I was in Harvard attending Massachusetts General meeting. And as a board member, the report that we received was from a team from Mass General who were in Japan. To do what? To offer assistance, because there was a disaster there. So we need to understand that every society, whether it is rich or poor in the world, it needs assistance. And Mass General has got a motto. It says, in times of crisis, in times of disaster, everybody is your neighbor. And this is the philosophy in the global village now. So when there is a crisis in Africa, the same crisis can happen anywhere in the world. And we need, as human beings, to be able to address it. That's why we have United Nations, where all nations come together. Why we have international treaties. We need to be able to address those. But in these other organizations we belong to, we need to work towards eventual self-sustainability. I think I made that point clear. On that basis, we request Uganda government and all the African government to make sure that AIDS is on their agenda, and that every time they are increasing it step by step, so that the donors can look at a time when the countries will be able to sustain this treatment, this program. So what has Uganda done? Uganda has the government spent a lot of money. It contributed a significant amount of money to start a generic manufacturing factory right in the city of Kampala, to produce cheaper generics which can treat more people, not from India, but from the country itself. Secondly, the government put for the first time AIDS on the program. And every year, we want them to keep increasing the amount they contribute, because ultimately, it will be our responsibility, not only as Uganda, but entire African countries and other countries like Haiti and others to shoulder this program. Now, your second question about structural adjustment. Those of you who may not be aware, in the 1980s, the World Bank prescribed a very tough program to Africa, whereby there was mass laying off of civil servants so that the countries could start afresh. It was at that time that AIDS was its height. Most of those civil servants who were laid off had many dependents who were AIDS sufferers, and many of them. It caused a lot of turmoil in the country. That program was a most destabilizing program. Eventually, it was abandoned. Part of that program involved all public sector not employing anybody anymore. I saw its effect in Kenya because I was a consultant trying to see why Kenya was not succeeding in treating many AIDS patients. I went to one regional hospital. I found one surgeon. He was doing gynecological surgery, orthopedic surgery, abdominal surgery, name it. One doctor was doing it. Down in town, in Kisumu, the town was full of unemployed doctors. World Bank had said no more recruitment of civil servants. So this is part of it has since changed. And I don't know precisely what effect it had on AIDS, but it certainly didn't help the situation got worse. And this is why I was mentioning here that when you have programs like this, they need to be planned with the countries. You can't have a program that cuts across. Even AIDS program cannot cut across all countries. In Africa, we have some of the countries which can do AIDS program by themselves. A country like Botswana is rich enough to treat virtually everybody. South Africa should be able to take on more responsibility by itself. As countries emerge from their economic situation, they should take on more and more responsibility. Yes?
Oh, I'm Chelsea. I'm a master's student here at Duke. that you didn't talk much about prevention within your program or within your sites, and just that's obviously an important part, and a part that is getting more and more publicity as well.
Yeah, so I will be very brief. The President Obama's program of global health was absolutely well received, and it's a fantastic program. Because when you look at it, there is AIDS, which was getting funding, but there is these other diseases. Some of them are neglected diseases, which never get funding because they don't make money for pharmaceutical companies. Others are equally devastating in poor countries. So this was a very, very good program to address global health in addition to HIV/AIDS. But as I explained, you saw those beds, they were full of AIDS patients. If you take your eyes off AIDS, it becomes worse and makes it very difficult for you to deal with other diseases, as was happening in my pediatric ward where I used to work. So global AIDS needs new money. It should not take money from AIDS. All of them need to be supported. And I think there was a program to increase funding so that both could be supported. Without new money or policies, which I have explained, where we can save money from some of the other programs to go and bring up global AIDS as a whole, we fail on both. But there are initiatives which can make it succeed. And these initiatives include some of the strategies that I've talked about. For example, integrating AIDS money to be able to do more than AIDS. The laboratories that we set up for AIDS using PEPFAR should be able to work on the expanded program. But the bottom line is that we truly need to take both, but not at the expense of the other. Both of them are very important, and we need to support them as President Obama planned so that they succeed and not have one at the expense of the other. Yes?
So most of the HIV programs in Uganda are standalone programs, independent of other healthcare systems.
Yeah.
The potential role of integrating HIV care programs in hospital care.
It is the ultimate goal that will ultimately ensure sustainability. The standalone programs have to be created so that they become a continuum of care. And I think that's the road that we need to take. The only problem that we see with that is doing it prematurely. If you do it prematurely, it fails. But you need a stepwise program, like my center did. We have actually transitioned the majority of our clinics into the public sector so that we don't need to, and that's where they will always be. And our role now is to make sure that they are working very well. Yes.
My name is Sanford.
Yes.
Probably recognize that name.
I do.
What's the political will currently in Uganda about AIDS or about those programs? And another thing about the reduce the wastage. A few years ago, there was a problem with the Ministry of Health. A lot of money was lost or was misused. People were prosecuted, some were sent to prison, some were not, especially the big fish. If I mention a few names, probably you know
Yes.
about it.
Yeah.
Jim Mwez,
Teddy Sezche is in prison.
Mukura,
Yeah.
but in running for elections recently, so
Yeah.
they're out.
Yeah.
They get the biggest champion.
Yeah.
And another question is about the factory you talked about,
Yes.
the ARV factory.
Yeah.
What's its capacity and how much does it contribute percentage-wise for you?
To the drugs, yeah. Those are very good questions. That's what I talked about in my presentation. Absolutely, donor money should not be misused, stolen. Accountability is key. And without accountability, you don't deserve to get donor money. Because, as I said, this money is, people work for it. It is not free money. It is money that people get. So that's why those people are prosecuted. But those who are not prosecuted, we need to do more to make sure that every coin is returned. Currently, the process of returning the money that was taken has been fairly successful. It's not complete, but it is going on. And I'm with you, your concerns. That's what I presented here. Donor money should be used maximally. And when it is misused, we should not punish patients. We should punish the thieves, not patients. With regard to your second question, the capacity of that factory is not yet substantial because it is newly built. It is an investment in the future. When you build a new factory, it cannot beat the established one. You have to recover your investment money and others. But already it is producing drugs, and incrementally it should be able to produce virtually all the drugs that the country needs for the first line. It is already exporting drugs and has signed contracts to neighboring countries. So the capacity should be fairly big. The company is not owned by government. It is a private venture which government invested in, and it has linkage with some Indian successful generic manufacturers. Yeah. Yes. Behind. No, behind you, then you. Yes. Mm. Yeah.
Thank you, Dr. Mugyenyi. Two quick but related questions.
Yeah.
To ask you to briefly comment on your perception on how stigma in Uganda has changed over the years, and if PEPFAR's decision to fund only abstinence-only programs had an effect on that. There's been some writing that had, well, PEPFAR had a lot of great things that had a detrimental effect on kind of the perception and the prevention programs. And then similar to, along those lines of stigma, Uganda's received a lot of press in the past year about the criminalization of homosexuality.
Yes.
Primarily from international AIDS activists. And
Yeah.
how that is playing out on the ground. You see that happening.
Yeah. Well, those are good questions. Stigma is lower in Uganda than most other countries because of treatment. Part of the driver for stigma was actually the fear of death. And when treatment is available, people got to know that they wouldn't die. And record numbers, you saw the clinics I showed you, it was chock-a-block full of patients. In the past, they would come stealthily, they would hide. So stigma did come down. It's not as bad, but it's still there. It's still there, and we need to continue to fight it. There was an act of parliament. Someone tried to pass an act of parliament against homosexuals. It was fought mainly by Ugandans, and it's moving nowhere. The reason why it was being fought, it's no different from any form of discrimination. It's a discrimination. And we don't support it because it's a discrimination. We don't support discrimination. So that act is not supported by many of us. And we are strongly against it. And Ugandans themselves are the ones who are fighting it more than the international community. Yes? Mm-hmm.
Yes, so you're asking my questions.
Yes.
I'm from Kenya.
Yes.
I've been working also in HIV.
Mm.
And I've seen prevention of mother-to-child transmission has been kind of like a winning strategy, and I consider it like one of the potential ways to break the tide of HIV. What, in your opinion, and what kind of statistics are there?
Yeah. Yeah, all of us, we need to know that we can achieve close to 100% success in the prevention of mother-to-child if we only can treat the mother. Yesterday I was talking with the some Harvard students and saying to them that here in the United States, if you want to research on pediatric AIDS, you have to take a plane and come to Africa. In virtually all the hospitals you go to in Africa, there are kids with AIDS. But here in the United States, thanks to antiretroviral therapy, unfortunately, even here we still get some mothers giving birth to some babies who are affected, but they are very few. It is no longer a public issue. So this is an area where we can succeed. I myself, I am a board member of a project that is fighting to have full access for pregnant mothers so that we can have an AIDS-free new generation. So that's where we need to work hard. But currently, we are not covering, we have not reached 50% of the mothers who need treatment for prevention. And in Uganda and even in your country, we haven't reached that. So the last question or two, yes?
Yeah, I was wondering if you could talk a little bit about the distribution of the regional distribution of the people who are able to receive ARDs, and maybe if that's at all driven by organizations that are coming and where they decide to locate themselves, or where the money is.
Yeah, the people who are not accessing treatment always are the poor people. Some of them have not had information, and others are living away from the facilities where the treatment is. Because currently, as I explained to you, we now have got enough drugs for everybody who comes. Previously, we had an aggressive program of going into the villages, of reaching people everywhere, but because of funding has been reduced, there is a reduction on that program where we are trying to reach everybody. But we are trying our level best to have announcements, to have people living with HIV and the community themselves reaching others to inform them that treatment is available so that they should come and access it. So currently, the situation is a little bit more complex. I didn't want to go into some of the issues. Currently, we reach about half of the people who need treatment. But we are using a very old criteria for starting treatment, which is 200. We are not using the current World Health recommendation. There was somebody who asked, what happens when you start early? When you start early, you get excellent treatment outcome. You get no complication. You eventually save a lot of money because people don't get expensive diseases like toxoplasmosis, brain diseases, and so on, and cancers. So we are reaching about less than 50%. But now, if we said we must go to 350, the numbers would soar. So we are treating a small number so far. But presently, as I said, everybody who needs treatment now comes to our clinic. We don't turn away people. But as our fear is that we'll soon reach that number and start turning away people. That's why I'm talking to you. We should not reach that situation. We should be able to talk to our leaders, to talk to Congress and senators, and me, I should be able to talk to my government and others so that as a world, we do not allow that situation to come. Because as I said, we have to treat our way through the epidemic. If we don't, we cannot live with the consequences.
Any other final questions? Well, let me thank you for being such a strong voice, Dr. Mugyenyi, for actually those who have none. And also, you are really an example to us all of how to actually combine scientific evidence, caring for patients, and most importantly, advocacy for them, and how it comes together. The respect that Duke University holds you, actually, and the important contribution you're making to the global struggle against AIDS, I think is reflected in the co-sponsorship of this event. It was an easy task to bring together a number of groups around campus to support your coming here, including I want to acknowledge the Duke Center for HIV/AIDS Vaccine Immunology, CHAVI, the Duke Global Health Institute, the Duke Center for AIDS Research, our students actually in the Duke Partnership for Service, Domestic and Global Health Outreach Branch, and the umbrella of student groups who actually came together to bring all of this, the news, spread the word of today's event. and the Sanford School of Public Policy, which invites you to join us in a reception following this talk, where you are to be on the first floor of the main floor of this building, where you can hopefully continue discussions with Dr. Mugyenyi. Finally, for coming such a long way, so that we might be inspired to continue to actually do our part, which is to support the political will of our government, so that you and others may be able to continue the remarkable struggle and important work of actually saving all those lives touched by AIDS. Thank you so much, and please join me actually in thanking Dr. Mugyenyi.